let's imagine a patient. Let's call her Mrs. M. She's 46 years old. She's got 2 kids. She's got a mother. Her mother is a little frail. We're trying to take care of her. She has type 2 diabetes. It's not really well controlled. She's got some mild heart failure as well due to some issues that happened when she was a kid. She's holding down a job. She's got a high deductible health plan with her employer. She's trying to make ends meet. She's dignified and takes her responsibilities very seriously. She makes sure that her kids get to school, are fed, are doing well, and taking care of her mother, who relies more and more every day on her. So let's take Mrs. M. What does the AAA mean for her? Well, we know that in Mrs. M's story, for instance, when she gets admitted to the hospital because she has, which is common for patients like diabetes across the country, a hypoglycemic event, low blood sugar. More often than not, we're just beginning to understand in healthcare that the root cause of stories like Mrs. M, diabetics are getting hospitalized, especially at the end of each month across the country at a much higher rate. They're being hospitalized because of food insecurity. In other words, she's at the end of the month before she got hospitalized, she was taking care of her mom, she fed her mom and fed her kids, she paid the rent, she paid for all the utilities, and then she skipped her own meal because there wasn't enough food left over after taking care of everybody else. And yet she still took her blood sugar lowering medications, right? She was adherent to her care plan that we had come up with together. She took her blood sugar lowering medications, didn't have food, and ended up getting hospitalized. This is not a unique story, right? Patients like her get admitted at a rate almost 30% higher than other food secure diabetics. So if we can't address her food insecurity, she's not going to be happy with her care. And I've taken care of patients who are consistently frustrated with the fact that their healthcare system, their healthcare providers are not asking about some of the basic stuff that they know is happening in their lives. I have mold in my home. That's why I have my headache. Or I have a problem actually making ends meet right now, and that's why I can't afford to take that medication. Why are you making me have to tell you this? Right? There's anger from a lot of patients. Patient experience connected to the social determinants of health. You think about total cost of care or even per capita costs. When that patient gets hospitalized, Mrs. M gets hospitalized right now, we have an avoidable ED visit and avoidable hospitalization right now. That's dollar signs, and that's per capita costs going up. If we don't address food insecurity, that will continue to happen. Social determinants of health connected to per capita costs. We think about the outcomes of patients like Mrs. M, of a community of folks who live in and around her community, as well as people who have that condition, diabetes. Well, there's no way we can improve outcomes for whole populations of patients in defined communities or with certain conditions like diabetes unless we address food insecurity or other social determinants. So we think about the triple aim, patient experience, the improving outcomes for populations, and lowering per capita costs, if not total costs of care. And every experience I've had, just like the story of Mrs. M, reinforces for me that we can't achieve the full potential of the triple aim unless we recognize that social determinants of health and integrating social determinants of health into our systems with partners in the community is related to each element of them. It is not extracurricular. It is not an afterthought. Every experience that we have in health and healthcare demonstrates that a necessary component of achieving the triple aim requires us to address social determinants of health.